And certainly I'm sure that Caton means what he says when he says he's happy to be contacted. So next, we're going to move on to our only live speaker, Dr. Li. So Dr. Li, if you'd like to come up. Dr. Li is a specialist registrar in infectious diseases at Imperial and is also a clinical research training fellow at the MRC. Prior to that, he was in Oxford as a clinical research fellow, and that's when he was the trial physician and lead author on the OVIVA trial, which Caton has already mentioned. So we're looking forward to hearing about that in a little bit more detail. Thank you.
Well, thank you very much to the Malvern Diabetic Foot Committee and the chairs for the warm invitation and also for the introduction from Fran. As she said, I am an academic infectious diseases trainee, and I'll be talking about the lessons from the OVIVA study. And I'm absolutely thrilled to hear about how the infection service is providing useful input to all of the multidisciplinary team meetings. So many of you in the audience will be familiar with this. Certainly in a year we see a vast number of joint and fracture procedures, and certainly in elective surgery up to around about 2% of those become infected, and with rising comorbidities, diabetic foot osteomyelitis is definitely on the rise. It's very costly to manage these patients, so around about £20,000 to £40,000 per patient in order to manage their infection, and the current practice has always been to give them prolonged courses of high-dose intravenous antibiotics. And as you all know, this is associated with significant inconvenience to the patient, despite the fact that they're given antibiotics via an OPAT service, which is outpatient antibiotic therapy service, and also the inherent risks with having a long line in situ for 6 weeks, and also, as I mentioned, the costs involved. Now, where did all of this come about? Now, certainly throughout my medical career, I have seen various textbooks, the cheese and onion guidelines, up to date, that all stipulated that actually these patients need to have long courses of intravenous antibiotics. And it appears that this all stems from this pivotal paper published in 1970 in the New England Journal of Medicine by Francis Valvogel, who stipulated that osteomyelitis is rarely controlled without a combination of careful surgical debridement and 4 to 6 weeks of intravenous antibiotic therapy. Now, since then, quite a few authors and studies have actually tried to postulate that there is an alternative to this. So certainly Greenberg in 1987, down to Maeder, Gentry, Gomis, Schrenzel, and Yuba in 2009 have put forward studies to suggest that actually oral antibiotics is a possibility. But this hasn't changed clinical practice. And probably the reason for that is because the numbers of participants have been small, or they've been too restrictive in terms of their trial design or their study population, so they weren't readily able to apply the findings of their study to general orthopedic infected patients. So this is where OVIVA came about, and this was, as mentioned by previous speakers, published in 2019, which is almost 50 years after Francis Valvogel's publication. And I think it's quite poetic that actually it's come back to the New England Journal to bite them with a different opinion as to the outcome. So OVIVA is oral versus intravenous antibiotics for bone and joint infection, and this is a multi-center, randomized, open-label, non-inferiority trial. And essentially, we were looking to recruit all adults with any form of bone, joint, or metal wear infection, and they were then subsequently randomized to receive either a total of 6 weeks of intravenous antibiotics or 6 weeks of oral antibiotics. Adjunct oral therapy or follow-on antibiotic therapy was permitted but was closely monitored. And as my previous speakers have alluded to, the choice of antibiotics is really quite complex. And the choice of antibiotics was therefore made by an infection specialist who was aware of local microbiology, drug interactions, the resistance profile of the infection, and also drug interactions and bioavailability. All of these patients were followed up for a 1-year duration to look for treatment failure, and we set our non-inferiority margin at 7.5%. Who were the patients included and excluded? Well, I won't bore you with the small print, but essentially it's meant to be a very pragmatic, all-inclusive trial. So these are adult patients 18 years and above who were able to give consent. They had a clinician who felt they had a bone, a joint, or a metal wear infection. These were all included. And most crucially, they had to have less than 7 days of intravenous therapy, because that's what we're comparing. Who are the patients who were excluded? Well, it makes sense that actually if you had a concurrent infection that needed prolonged intravenous antibiotics, then we can't stop those intravenous antibiotics. So if you had a Staph aureus bacteremia, for example, severe sepsis syndrome, or infective endocarditis, then we also excluded you as well. Given the microbiology, if you had an infection that actually we didn't have any oral options for, then of course we can't include you into the trial. But also on the lesser side of that, if you had a mild infection that didn't warrant 6 weeks of antibiotics, then we wouldn't give you 6 weeks of antibiotics, if that makes sense. What was the primary endpoint? Well, we were looking for definite treatment failure, and this was measured by very hard endpoints. So you had to either have indistinguishable bacteria in the microbiology results. You also had the histopathologist coming back to us to say that actually there were definite features of infection, and also from our surgical colleagues who had irrefutable evidence that actually there was a treatment failure judging by their operative findings. So, for example, a draining sinus or pus next to a prosthesis. We also looked at some secondary outcomes, so serious adverse events, line complications, Clostridium difficile infections, probable and possible treatment failure, early termination of randomized therapy, and also patient questionnaires and patient-reported outcome measures as well. Now, as I mentioned earlier, this is an open-label study, and the reason for that is because the number of different antibiotics we used, it's practically implausible to actually create a placebo for all of those different types of antibiotics. And I also challenge anyone in the audience to go and approach an ethics committee and say to them they want to take 500 patients, put in a line for 6 weeks and give them saline for that duration of time. Now, in order to counteract that, we had patients who were, if they had a suggestion of a treatment failure, then they would be managed according to usual practice, and their set of notes with all of the results of radiology, microbiology would subsequently be sent to me. I would go through those notes with a black marker, and I would mark out or delete anything that would betray the route of antibiotic administration. And these sets of notes were then subsequently submitted to an Endpoint committee, which was chaired by Benjamin Lipsky, 3 experts who then decided whether there was no treatment failure, a definite treatment failure, possible or probable treatment failure. Now, I had real pleasure in going to all of these 26 different collaborator sites. And I have to say, if you work at one of those red dots, then I sincerely thank you from the bottom of my heart for making this happen. If you happen to recognize one of the photos, then at some point you really have to come to me and I'll have to buy you a drink because you're one of our top recruiting collaborator sites, so thank you for that. So what did we find? Well, the table is quite small on the left, but what I really wanted to demonstrate here was that there was actually quite equal spread between the two groups. So we recruited 1,054 patients, so 527 in the oral arm, 527 in the intravenous arm, and actually they were very well matched in terms of their baseline demographics. In addition to that, also to the type of surgery that was performed, the microbiology, and also the diagnosis, so for example, the histological findings between the two groups. Now, as Kitan has alluded to, and also Andrew would never forgive me if I didn't actually go into the nitty-gritty details of it, the number of patients that had diabetes, it's no surprise that actually diabetes was our top comorbidity, accounting for about 20% of our study population. Those who had a foot infection also accounted for around about 20% of our population. But actually, if you really drill down to it and say how many of those patients actually had diabetic foot infections, well, they accounted only for just under 9% of those patients. Now, this didn't formulate a vast proportion of our study population, but importantly, they also were not excluded from the actual study itself as well. Now, what was the primary endpoint result? Now, you may have seen this slide from Edgar from earlier on, and essentially this is a forest plot of the risk differences for definite treatment failure, and if you're not familiar with it, pointer. That's okay. That's right. So the forest plot, where you can see on the graph on the right-hand side is anything on the left that says oral better. If you have a result that's on that side, that it means that oral therapy is better. Anything to the right means that intravenous therapy is better. And the hashed line at 7.5 is where we marked our non-inferiority margin. The solid dot is the actual result, and then the line extending from left and right to that is how confident we are about that result. So what you can see here is, depending on the type of analysis that was performed, whether it is the intention to treat analysis, the modified intention to treat analysis, whereby patients have had at least 4 weeks of their 6-week allocated regimen, or patient participants who stuck rigorously to their protocol. Now, any of these analyses has shown that actually oral antibiotics is non-inferior and met the non-inferiority criteria, which we set at 7.5%. In addition to that, with any randomized controlled trial, we know we lose patients to follow-up. And this is no different here. We had around about a 4% loss to follow-up, and in this particular scenario, we actually did a worst case scenario analysis. So what we did was any patient who was assigned to the oral regimen who was lost to follow-up, we automatically assigned as being a treatment failure. Anyone who's assigned into intravenous group who was lost to follow-up, we assigned them as treatment success. So we're artificially creating the worst possible case scenario. And even in that situation, the non-inferiority margin was still intact, and we can call that there was non-inferiority with oral antibiotics. So hopefully this is quite some compelling evidence. Now, specifically with regards to diabetes, the number of patients who had a treatment failure that had diabetes was 13.4%, and those that didn't have diabetes was 14%, and that created an odds ratio of 0.95 without diabetes and 0.66 with diabetes. But I have to emphasize here that actually the numbers are small and therefore was underpowered, so we don't have, or rather the confidence intervals is severely overlapping. We also did some post hoc subgroup analyses, and particularly for the orthopods, the orthopedic colleagues in the room, we couldn't find a form of surgical procedure that actually meant you were more likely to have treatment failure with oral antibiotics. And this was whether you had osteomyelitis debrided, not debrided, whether you had implant retention, or whether you had a removal of metalwork. If you group that together in terms of metal preserved or metal removed, again, we didn't show a specific odds ratio that favored failure. Particularly for the infectious diseases or microbiologists, we specifically were looking to see whether a particular pathogen was more likely to have failure with oral antibiotics, but unfortunately the study wasn't geared towards looking at a specific pathogen. And the reason why we don't have any results for Pseudomonas is because we didn't have failure in both arms of the study. Now, particularly for the vascular colleagues in the room, we also looked at whether peripheral vascular disease played a part in increasing your odds of having a treatment failure. But as you can see from the massively long line at the bottom, we weren't very confident about the results, so unfortunately we weren't able to show that as well. And again, the study in itself was not geared towards looking at peripheral vascular disease. Certainly the secondary endpoints, well, it's no surprise that actually almost 10% of the people in the intravenous group had a line complication that required intervention. And this was highly significant versus the 1% in the oral group. Now, you may ask me, actually, why is it that patients in the oral group had a line complication? Well, actually, it's because these patients were assigned to oral antibiotics, subsequently were felt to have a treatment failure, and then were switched to intravenous antibiotics for their treatment, and then, unfortunately and ironically, subsequently developed a line complication as a result of that. In the serious adverse events, we did have quite a high number, so 1 in 4 patients had a serious adverse event, but they were equally matched in both arms. But most importantly, the length of inpatient stay was significantly shorter in those who were treated with oral antibiotics, so they were discharged at least 4 days earlier in comparison to those who were treated with intravenous antibiotics. Taking that aside, just looking at the health economics-wise, those patients who were treated with 6 weeks of antibiotics orally, we had a cost saving of at least £2,740 per patient versus those that were treated intravenously. Now, to all of my diabetes colleagues in the room, how well do you know your patients? Now, certainly because this trial is looking at oral versus intravenous antibiotic therapy, we also need to look at adherence. And as part of the trial, we procured 100 of these electronic pill bottles or medication event monitoring systems, as you can see from the picture. And what it does is each time you open and close the cap, it time and date stamps what happens. So you get a picture that roughly looks like this. Now, for this particular patient, as you can see, it looks exactly at what time you opened the pill bottle and what time, so that's a surrogate of when you took your antibiotics. And if you put that into a calendar view, then it allows you to work out exactly how compliant they were during their 6-week duration therapy. And I have to say to you, this was 71% for a lovely lady who assured me, she's retired, lives in Oxfordshire, and she guaranteed me that she was the most diligent and devoted patient in terms of taking their antibiotics. And this is only for a 6-week duration, not lifelong therapy, just 6-week duration, and they know how severe their infection was. So in terms of adherence, so we collected these bottles at 42 days. I told you we procured 100 of these bottles at a cost of 125,000 euros for these bottles. And we only had results for 62 of them. And why is that? Because some of them ended up in the bin, some of them were put through a dishwasher, some of them were put in a refrigerator, and I've even seen them appear on eBay, unfortunately. But what you can tell here, actually, is that only 51%, so almost 50% of patients were 100% adherent to their 6-week oral antibiotic regime. Okay, and actually, it's probably too small in the table there, but on the table on the right-hand side, 2 of the patients only had a 45% and a 53% compliance, so they only actually took half of their antibiotic regime. And that's actually quite worrying, and I'm sure my diabetes colleagues give them something to think about in terms of lifelong anti-hypoglycemics. Now, of course, there are limitations in the study in that it is open label. We tried to counteract that by using a blinded endpoint committee. There is a real mishmash of surgical patients, the heterogeneity of the participants, but hopefully that was counteracted by doing the randomization so they fall into both groups, but also it allows us to apply the trial findings to a more generalizable group of patients. And the follow-up of 1 year, we may be criticized that we may miss the very late recurrences, but actually it's a very pragmatic trial, and clinically this is what we usually do in terms of a 1 year follow-up. So hopefully I've been able to convince you that oral therapy is non-inferior as compared to IV therapy when it's used early in the treatment of bone and joint infections. We think it's good for our patients, it's good for practice, and also very good for health economy. And if you were to extrapolate the cost saving of £2,740 to the number of cases that we see per year, that equates to around about £16 to £25 million saving per year. So that's in the context of a clinical trial. What about outside a clinical trial? So certainly those who recognise this is the University College London Hospital, which was not one of our collaborator sites because they only give 4 weeks of intravenous antibiotics, so they couldn't take part. But essentially what they've done is they've published this report of where they've tried to implement OVIVA criteria to their patients treated in the OPAT service. So essentially, for a 3-year period, they looked at all of their bone and joint infection cases. All of these patients were treated with intravenous antibiotics, and then they had an infection specialist who reviewed all of those cases to determine how many of them would have been suitable for an oral antibiotic regimen. And they applied all of the same criteria that we applied in our clinical trial. Now, what you can see here in terms of this table is that there's a real spread of the type of surgery that's performed, so, and also the diagnosis. So you've got discitis, diabetic foot is in there, which is not excluded, prosthetic joint infections, and also the range of surgical interventions that's been performed as well. Overall, they had 133 cases, and staggeringly, 106 of them they felt were suitable for an oral antibiotic regimen. Now, all of these patients were actually treated with intravenous antibiotics, but 106 of them could have had an oral antibiotic regimen. So the vast majority of the cases had a surgical procedure, which is very much in keeping with our clinical trial data, where about 80% of patients had a surgical procedure. Almost 80% of those patients were suitable for an oral antibiotic, and only 10% of them couldn't have oral antibiotics because of resistant microorganisms. Their cost savings was modest at £1,234, but actually that was for only a 4-week duration of a 4-week duration of therapy, and if you extrapolate that up, that would be over £2,000 as well. How about the second site? So this is the Royal National Orthopaedic Hospital in Stanmore, which is a specialist orthopaedic hospital with a bone infection unit. And this was one of our collaborator sites up until around about late 2015. And what they subsequently did is they looked at a pre-OVIVA and a post-OVIVA implementation study. So there was a prospective arm whereby they looked at it after OVIVA implementation between 2017 to 2018, and they also did a retrospective aspect of it, so before OVIVA between 2016 to 2017, and compared their outcomes. And they, of course, collected the same amount of data and applied the same OVIVA study protocol as well as we did. Now, hopefully what you can appreciate is that in the pre-implementation and post-implementation arm, they're roughly equal in terms of their baseline demographics and also the type of procedures, but certainly there are some higher numbers of, say, a one-stage exchange, and also the debridement in the chronic osteomyelitis there is higher in the post-implementation group, but certainly in the oral versus IV group, they're relatively matched in terms of what they have in both groups. Now, what they subsequently found is that looking at the Kaplan-Meier curve at the top, which is the cumulative infection-free survival, the post-implementation arm is lower than the pre-implementation arm. And if you look at the table at the bottom, you'll see that actually definite treatment failure in the pre-implementation arm, there was a 13.6% treatment failure, and after implementation, they had an 18.6% definite treatment failure. Now, when I first saw this, my heart actually stopped. But subsequently, if you really drill down into the details, and actually, so pre-implementation are everyone who's treated with intravenous antibiotics. Post-implementation is the vast majority are treated with oral antibiotics, but some of them actually stayed on intravenous antibiotics. And when you subsequently drill down to it, In the post-implementation subgroups, 26.7% of the treatment failures occurred in the intravenous arm, and actually only 14.3% occurred in the oral arm, which is much more comparable to the findings in the OVIVA trial. So their conclusion was that actually a vast proportion of their patients could have been switched to oral antibiotics and managed with oral antibiotics, and they would have a 10% more increase if they included culture-negative regimens. Their treatment failure is broadly similar and comparable to OVIVA, and the oral group had at least a 50% lower treatment failure versus the intravenous group. They did have a higher adverse drug reaction in the oral group, but their length of stay was also 4 days shorter, and also had £14 more cost saving than we did in the OVIVA trial, about £2,764. So hopefully I've been able to convince you that actually the OVIVA trial findings can be safely implemented into clinical practice, and it really requires a multidisciplinary team to make sure that actually you've got the right patient who is adherent to therapy, you've got the right surgical colleagues who are doing the right surgery, and actually you're choosing the right drug for these patients. And I'd love to hear from everyone to see if they were able to use oral antibiotics during the COVID pandemic. So I want to thank all of the participating collaborator sites, all of the research staff involved, all of the patients and participants, and also the National Institute of Health Research who funded the study. And as you can see here in the white on the left, that's Claire, who's one of our research fellows. Then it's Matt Scarborough, who's the chief investigator. The lady in the orange in the middle is Rhea, who is our trial coordinator. And then to the left of me is Ines, who is our statistician, and then you've got yours truly. And thank you very much for your attention.